Welcome to the third webinar on the Guidelines 25 on resuscitation. My name is Tino Greif. I'm the current director of Guidelines from the ERC. I'm a retired professor of anesthesia, intensive care medicine and medical education, and it's a pleasure for me to host this webinar to get together with Natasha.
Hello everyone, I'm Natasha Parthenou. I'm an anesthesiologist and emergency medicine doctor from Greece, and I was also a member of the ERC Guidelines Steering Committee for the guidelines of 2025. Nice seeing you everyone here.
Only a few housekeeping stuff. You see this QR code. The recordings of the first two webinars is on the ERC YouTube channel, and the webinar will be also recorded and will be soon available also on this YouTube channel. Important, if you have a question, and we hope you have a lot of questions, please type in the question in the Q and answer box on the bottom side of the Zoom screen, and we will sort them out while we are going over these different topics. Today we will cover two clinical topics and two non-clinical. So we start with neonatal life support, then we dive into education, ethics of resuscitation, and we close up with first aid. Natasha, last point for you.
Yes, as you said, the webinar is recorded and can be found in the YouTube channel of ERC. And also, if anyone requires a letter of attendance, please send an email to webinar@erc.edu. And in order to gain more time for our speakers, let me introduce our first speaker, which is Marie Hogeven. She's a neonatologist from the Netherlands and was the lead author of the NLS chapter for the ERC Guidelines 2025. So Marie, the floor is yours.
Yes, good evening, everyone. It's my pleasure to be able to talk about the key changes in the ERC NLS Guidelines 2025. And I know some people think that, the very tiny humans are very scary or sometimes even called aliens, but I just want to assure you that simple steps can save lives. I think that's the main message for NLS and maybe for a lot of things resuscitation. So let me guide you through the key changes. If the if the slides are working. We rehearsed this. Yes, I did. This is the publication in Resuscitation, as some of you may be familiar with. And I have, well, maybe, I'm not sure if these are conflicts of interest, but this is what I want to mention. I'm a member of the task force of the NLS. I'm the chair of the Science and Education Committee of the NLS and was the lead author of the writing group. And I'm a member of the Dutch NRC. So just to be completely transparent. If we look at the key messages and we start on the top, then we usually start with some decision on when to cut the cord, and then simple measures like drying, wrapping, putting a cap on the head of the baby, keeping the baby warm is usually enough. Most infants do not need advanced help at birth, so that's very reassuring. Everyone can do this. If you are in doubt, we need to assess the breathing and heart rate, and this will guide the next step throughout the neonatal algorithm. If the baby is not breathing properly, we need to do airway management and lung inflation. Chest compressions and drugs are fortunately rarely needed in neonatal life support and neonatal resuscitation. And if you are dealing with a preterm infant with a gestational age of approximately below 32 weeks, those babies require an altered approach. Slight, tiny differences, but they are important. And of course, there can always be the situation that there is an unexpected out-of-hospital birth. It may be at home, it may be in the supermarket or wherever. And then extra attention to prevention of hypoxemia and hypothermia needs to be paid. And throughout all these steps involve parents, so communication preferably before, to give them proper information and set expectations, but also during and after birth is key. If you look at the major changes, I think this is a very good addition, because we used to receive many questions on when to use NLS algorithm, when to use the pediatric basic life support or advanced pediatric life support algorithms and content. And so together with the pediatric group, we drafted some advice on when to use which algorithm. So NLS is supposed to be used immediately after birth, irrespective of the birth location. So whether it's in the hospital, at home, or any other location. One can consider to use the NLS guidelines as well during NICU stay, and then especially in preterm infants or in term infants with primary respiratory problems. Let me put you away. The pediatric life support guidelines are definitely supposed to be used after first hospital discharge, and it's very reasonable to use them as well during first hospital stay after birth in the following circumstances. So, for example, after cardiac surgery, in known cardiac arrhythmia, or in other definite non-respiratory cardiac arrest situations. I guess the most important thing is that you need local policies defining which guideline to use for which infants. And factors to take into consideration may include which typical case mix you have in your intensive care unit, how your healthcare professionals are trained, human and organizational factors. And you have to be aware that teams that initiate resuscitation may be followed up by teams more familiar with the other guideline. And so we need to be able to communicate that with each other and switch guideline if needed in a human factor appropriate way. So then on cord clamping. So the baby is born and is still attached to his mom through the cord, and we have to make a decision on when to cut it. Well, the general recommendation is wait. Wait, use the time wisely. So dry the baby, wrap the baby, keep the baby warm, put the hat on, and do your initial assessment. And usually at least 60 seconds have passed since then. And that's what we aim for. Try to wait at least 60 seconds before you cut the cord. And we definitely do not recommend cord milking in the preterm babies, especially below 28 weeks, because it's associated with increased risk of interventricular hemorrhage, and we definitely do not want that. If you look at assessment, we try to make it a little bit simpler and easier to read and categorize your babies according to your initial assessment. And we will not go through this whole table, but it is in the guidelines, and it's very helpful to put on the wall next to the algorithm, and to help you guide through the algorithm and help you practice with the algorithm as well. So basically, it's about your assessment, about the classification, and the appropriate interventions that need to be undertaken according to the initial assessment. If you look at the changes with regards to airway, these are the three main things that I would like to mention. Research showed that the two-person technique is actually more efficient than a one-person technique. So if you have enough people, use a two-person technique, especially when mask ventilation is difficult. A supraglottic airway device is a very appropriate alternative for intubation, but also for mask ventilation. So be aware of the possibility and use it wisely. Of course, you need to have an appropriate size for the baby that you are dealing with. And if available, the use of a video laryngoscope is recommended because your chances of intubation at the first time are definitely higher, and it's easier to teach as well. But that's a side note. If you look at the changes in the airway, then we more explicitly recommend using a supraglottic airway as a primary alternative for mask ventilation, as I just mentioned, but also if mask ventilation is ineffective, or as an alternative for intubation. And of course, if intubation is not feasible, either because of people who do not have the competency to intubate, or because it's difficult to intubate, or any other reasons. And it's also recommended to either consider a supraglottic airway or a tracheal tube when chest compressions are indicated. And with respect to intubation, we recommend that, of course, you need to consider intubation if equipment and skills permit, And especially if you already may expect that prolonged ventilation is necessary, for example, in a child with congenital malformations or whatsoever. And of course, also when ventilation with face mask or nasal interface or even with supraglottic airway device is ineffective. There are very rarely babies that need endotracheal suction, and then a tube is very convenient as well. And consider intubation or an SGA when chest compressions are indicated. If we look at the changes in B, they're detailed. There are only minor changes. We put emphasis on the fact that you can either use a face mask or a nasal interface to start your inflations and ventilations. We recommend to use a PEEP or CPAP of 6 centimeters of water, just to be clear about the advice on that level. And we provide slightly altered target SpO2 ranges for 3, 5, and 10 minutes after birth. So those are the major differences with regards to target ranges and interfaces. And then the initial oxygen concentrations for preterm babies have been altered. So we have two groups, greater than or equal to 32 weeks, we start in room air like we did before. But in the group below 32 weeks, you can start with 30% oxygen or more. So the literature is inconclusive to recommend a specific initial oxygen concentration. Anything from 30% to 100% would be appropriate. And the recommendation is to preferably use research or studies to try to evaluate new initial oxygen concentrations. So if we look at the changes in the circulation part, they are very minor. I think only the two words "at least" have been added to put emphasis on the fact that if the heart rate remains below 60 beats per minute, despite effective inflations and at least 30 seconds of effective ventilation, you need to consider chest compressions. But if heart rate, for example, was like 10-ish and it's already increasing during those 30 seconds of effective ventilations, it might make sense to continue ventilations for a little bit longer and see if the heart rate remains increasing. Probably you would be better off by not doing chest compressions immediately then. And we emphasize to consider an SGA or tube when chest compressions are indicated, as I mentioned before. So with regards to the D, which is drugs in the neonatal algorithm, we aligned to administer adrenaline every 4 minutes. It was like 3 to 5 minutes, and it was in daily practice really unclear. So we just used the middle number to make it very clear and aligned with other resuscitation guidelines as well. And we advise to only give glucose during prolonged neonatal resuscitation if you have actually measured the blood glucose and it is truly low. So not routinely supply glucose during neonatal resuscitation, even when it's prolonged. We aligned the amount of glucose, 10% to give with the pediatric section. So we advise the same amount, 2 mils per kilo of the glucose, 10%. And two previously mentioned medications, sodium bicarbonate and naloxone, have been removed from the guideline due to a lack of evidence, actually. We also have put in some information and tips on the unexpected birth outside of the hospital, also the expected birth outside of the hospital, where hypothermia and hypoxia are the main risk for the newborn. And we know that equipment and resources may differ and that you also need to transport the baby. So systems need to think about those factors in advance. And for example, in a planned home birth, the midwife needs to discuss with parents an escape plan, and also needs to know how in her region she can reach out to the emergency services and what the safest and fastest way would be to transport mom and the baby to the hospital. This is the complete algorithm, and I've only touched upon the changes in the 2025 guidelines. Of course, for all the background and the details, I refer you to the publication where all the information is published, including more graphs and picture, figures, etc. And I'm looking forward to answering your questions, if any.
Thanks, Marie, for this nice summary about neonatal life support. There are questions coming in. My first question which came up to my mind, for training purposes, for the general emergency physician or people who are not really always working with neonates, what do you think is the most important these people have to learn?
Oh, that's a very good question. So what I started with, actually, simple things can save lives. So if you would start with proper thermal management, and we can do that in any situation, wherever we are, we can use clothing to dry and wrap the baby and cover the head and keep the baby warm. And we can do our initial assessment anywhere we are. So also on the streets or in a car or wherever. And start with ventilations. That would save a lot of lives and are things that paramedics are used to do, only usually on bigger patients. So I would say simple things and just start.
I've a question which, for me, a kind of strange. Somebody's asking if you're not a neonatologist, if these guidelines also apply to them. So if you're simply an assistant.
It's a little bit depending on the local policies, but in general, the ERC recommends that every birth should be attended by a healthcare professional trained to do the things needed to perform a proper NLS resuscitation, as described in our guidelines. So if there is always another person, for example, the midwife, and you are the birth assistant, and the midwife has been trained completely, then the assistant need to know the basics, so they can really assist, but may not be able to do all the, for example, airway maneuvers by themselves. I think that's the nuanced answer to that question.
Marie, another question from the Q&A box. Someone of the participants is asking, why is naloxone excluded from the guidelines? So we had a discussion about naloxone.
Yeah. In daily practice, it was hardly used. Everyone from the writing group couldn't even remember the last time they had needed to use naloxone. And proper AEB management would solve the problem that naloxone is needed for. And there's also the discussion on you need to have proper ventilation before you should administer naloxone due to the risk of hypercapnia and maybe rhythm disturbances. That has been some debate going on about that as well. So because of it's hardly ever necessary, proper A&B management would solve the problem with patients sometimes without the need for medication and potential maybe slightly risk of the use of naloxone if ventilation was not done properly, I guess. So those are the major reasons that we excluded it from the guidelines.
Good.
Thank you.
Time is running. Marie, what would your take-home message for all of us from neonatal life support?
That newborn life support algorithm is a structured ABCD algorithm like any other resuscitation algorithm where simple things can save lives of the tiny humans. So please be aware of it and practice it whenever you can. If you are in the situation that as a healthcare professional, you may be needed at birth.
Okay, thanks a lot.
Thank you.
We are going on with the next part, which is on education for resuscitation. Sabine Nabecker, who was the lead in this guideline, will present the highlights from education for resuscitation. Sabine.
Hello. Good evening, everybody. Thank you for the nice introduction. I'm just trying to start sharing my slides. And I think they're working. So I'm talking today about the key changes in education for resuscitation. And before I start, I would just let you know about my personal biases. It's not really conflicts of interest, but I think you should be aware of who I am a little bit. So I'm a member of the ILCOR EIT, Education Implementation and Teams Task Force. And I'm also a member or a leading member of the Education for Resuscitation Writing Group of this guideline. I'm also a SEC IES member within ERC, and I'm an advanced life support instructor and an instructor trainer within the generic instructor course of the European Resuscitation Council. This is our publication, the Guideline Education for Resuscitation for 2025, but I am speaking on behalf of a whole team, as you can see in the authors list. We have authors from all over Europe that helped collaborate on this publication. Especially if you're a healthcare professional and especially if you're an advanced life support instructor, I'd invite you to read the full guideline, as I can only touch upon a couple of things today in this short amount of time given. First, I would like to show you where we got our resources from, and the resources are mainly the 2025 Consensus on Science with Treatment Recommendations from the ILCOR, the International Liaison Committee on Resuscitation. We also did reviews of peer-reviewed literature ourselves within the working group, and the rest was expert consensus. And within the guideline, we provide directions for lay people and healthcare professionals alike. We provide guidance for in and out of hospital cardiac arrests for all age groups. That's maybe a little bit different from the other parts of the guideline. Just as Mariah did, I am showing you the key messages here that we have within our guideline, and I'm not going to be able to talk about all of them. So I've just picked a couple of select things to talk about today. First, I would like to focus on the one that is circled in red right now, which is the team debriefing after cardiac arrest training for healthcare professionals, encourages routine clinical debriefings after real-life resuscitations. So I would like to talk a little bit more about that. So in the guideline, we have been writing that we suggest that team briefings are included in cardiac arrest training. So that is currently being practiced already in some parts of Europe where the ELS courses as well as the generic instructor courses already use this technology to actually do team debriefings after cardiac arrest training. And we think this should be done to encourage routine clinical debriefings after real-life resuscitations. And why is this important? Because we actually do have good evidence that in clinical practice, team debriefings have shown to improve outcomes, or at least do not have any negative outcomes. So I think this is an important thing for instructors to show to advanced life support participants to do this after cardiac arrest training. The next message I would like to talk about is that we recommend to teach teamwork competencies in basic and advanced life support simulations. I'm skipping over the ethical principles here because we're going to have a whole other talk on ethics a little bit later today. In terms of teamwork competencies, for me, there are two main messages. There are variable but mainly positive outcomes in relation to team competencies training, which means that has been shown in systematic reviews already. So that means we were able to recommend that we should include team competencies training in all life support courses, regardless of the level of training. And the other point here is that CPR performance in clinical and simulation settings was improved with the use of a CPR coach. Also, that has been shown in a systematic review. And therefore, we recommend now to consider a CPR coach as a member of the resuscitation team during a CPR simulation as well. Those are two things that might not always be present yet during resuscitation courses nowadays. The third key message I would like to touch upon, that we should educate all members of the community about cardiac arrest, and there's nothing new here about that, but that we need to adapt educational approaches and materials to the context, the target group, and resources available, especially in lower resource settings. So I want to talk a little bit about targeted training. And as you can see of the pictures that I've created here using artificial intelligence, it's about rescue diversity. So you have adult rescuers, you might have child rescuers, you might have rescuers that have some disparities or special needs. Then we have rescuers that are professionals. We have out of hospitals rescuers, we have in-hospital rescuers, and we have dispatchers. So there's a lot of things going on, and I might have forgotten some groups here, but you see there is a lot of diversity, and that we cannot do just one size fits all. We need to target our training a little bit towards those groups. And I think the guideline highlights that in an appropriate way. There is also the need to target the training to situations and especially to resources. If you think about our own hospitals in a high income area, we might not be the same as if we go to a low resource setting or to a remote area. I live in Canada. We do have a lot of remote areas in Canada, so I can very much vouch for that. It's very different if you are in a city or in a remote area within one country. There might be huge difference in the resources that you might encounter. So those trainings need to be targeted towards those resources or situations. The fourth topic I would like to talk today is about our recommendations towards technology enhanced learning. And I think that's something where a lot of information will come up in the next couple of years, and we might need to expect some changes here in the 2030 guidelines at this point. But we can recommend nowadays that we utilize online learning modalities, whichever you want, for flexible and asynchronous learning. We can recommend to incorporate augmented reality in life support training to possibly enhance learning. There is some evidence around that this works. And we recommend that you explore apps and artificial intelligence to support assessment and teaching resuscitation courses. However, those newer technologies, they do lack some evidence at this point, and there might be some more studies necessary, but we also can expect some more studies to come out in the near short future. An important part about technology enhanced learning in the context of lower resource settings is that we do need to recommend to apply distance and technology enhanced learning in remote areas and low resource settings so that we can target more learners in those areas and give them the appropriate training. There is a continuum of other topics, and this is just a word bubble that I've created for the purpose of showing what the guideline might be talking about in terms of training. So I invite you really to read those guidelines because there's a lot of information there, and we hope that you enjoy reading it. With that, I share again the key messages, and I will hand over back to Tino or the moderators to see whether there are any questions.
Natasha.
Thank you very much, Sabine. So first question is, do you recommend any certain debriefing models, and what about the scripted debriefing model, for example?
I am so sorry, I didn't catch that. It was very fractured on my end. It might be my connection.
Okay, I'll ask again. Sorry about this. So, what do you think about? Can you hear me?
What's that?
Yeah.
Okay, what do you think about specific debriefing models? For example, the scripted debriefing. I think Sabine is.
So Sabine, do you hear us? Okay, yeah. So I was part of this group. We have evidence that if you are doing a debriefing and you have a script, which means you have a plan what you are doing, and not free floating debriefing, then you are better overall for people who are starting doing debriefing, or if you're not doing this on a regular basis. So if you are doing debriefing every day, several times, because you work in a simulation center, then you can do whatever you can do easily. But if you have only one or two courses a year, then a scripted debriefing, which means you have a plan, which question should you ask, then you are more successful for the debriefing. Otherwise, there's no evidence that a specific debriefing model is better than another one. This is the same for different debriefing feedback methods.
Thank you, Tino. And should we move on with a few further questions, or
simply because there was a question, what is a CPR coach?
Yeah.
There are studies, if you have enough people in a team, if a specific person stands a little bit outside of the team and looks what they are doing and giving advice, what should be done, helping to structure the team, then the team is more successful in their performance. And the last question is, obviously, all this is called blended learning. So we mix the best of everything.
Thank you very much, Tino. Should we move on to the next speaker for the sake of time?
Yeah.
And this is Johannes Witting, who is a researcher, resuscitation researcher from Denmark, and was the lead author for the ethics chapter of the ERC Guidelines 2025, and also the past chair of the Young ERC Committee. So, Johannes, the floor is yours.
Thank you very much, Natasha, and thanks for the opportunity to present the Ethics and Resuscitation Guidelines to you tonight. Thanks for everyone joining and listening to these interesting topics, and I hope I can guide you through some highlights from the Ethics and Resuscitation Guidelines. So, of course, as with all the other researchers, there's been, and presenters, some conflicts of interest. I have some research funding and volunteer roles within ILCO and ERC. And of course, I was a co-author on this guideline. I think, first of all, I would like to thank also the other co-authors that have made this guideline possible. And also, I would like to highlight that we had some fantastic collaborators on this guideline. Professor Ulrich Kielbaum from Sweden, an academic ethicist, and Paul Swindle, a cardiac arrest survivor, who informed many of the discussions we had within our writing group. So, I think it is important to first also discuss who did we have in mind and what do we cover in this guideline. So overall, there are 9 topics. We range from advanced care planning, bystander and first responders, research ethics, education, as well as termination of resuscitation. They are shown here in the key figure, but there were also some other topics related to the family presence during CPR, CPR in the context of a suicide attempt, uncontrolled organ donation, as well as considerations for low resource settings. So as you can see, these are topics that are spanning across the chain of survival. They're probably interlinked with many other chapters, or maybe all chapters of the 2025 guidelines. And I think then the next question, who did we have in mind? Who did we write this guideline for? Basically, if you look at the topics, you will see there, of course, we had healthcare professionals in mind, but also patients and families, members of the public in general, researchers and society, but also educators and trainers. So almost everyone will find something relevant within our guideline. And basically, this has been done to have a foundation for ethical decision making in relation to resuscitation. So, focusing on the key messages here that we have, you can see there are 5. I'll go into 4 of them. And of course, there's many more to discuss. You'll see the QR code here in the right-hand corner that will remain there. That is a link to the full publication of the guidelines. But let's focus on the first topic. So the first topic that we covered and that we put up front was advanced care planning. And the key message here is, of course, to support patients' understanding and sharing their values and preferences as part of advanced care planning. And that here we wanted to be integrated, that there are DNA CPR decisions. And then, of course, the question should be who should receive or with whom should we have these advanced care planning discussions? And generally, that is recommended for all patients who want to have this discussion, who are at risk of cardiac arrest. And what is really important that is before this discussion is had, we recommend that there is patient-centered education that informs the discussion that is then later had with the specific healthcare provider or physician. What is very important as well is that these decisions need to be documented and accessible so that they can be used during a resuscitation or in an emergency context. And of course, patient preferences and also situations evolve, which requires updating on advanced care plans and regular reassessment. And then another key topic that we covered in this guideline is termination of resuscitation. Generally, we say that this should be made using a holistic approach, considering the combined picture of the situation, all prognostic factors, and patient preferences. Here, again, I would like to highlight this is a holistic approach, meaning it takes into consideration the whole situation and multiple factors or all prognostic factors, and it is never based on a single parameter. That is very important, of course, and many of you might know TOR rules, termination of resuscitation rules. We highlight in the guideline that these have been developed for out-of-hospital cardiac arrest in adults, and that they're not applicable for in-hospital cardiac arrest population, as well as they require for children, and they also require local validation if implemented. If a termination of resuscitation decision is taken by the team, it should be conducted in a planned manner. Good. Moving on to resuscitation research. Obviously, resuscitation research is critically important to advance our knowledge and our ability to help patients in cardiac arrest or after cardiac arrest. But cardiac arrest research, especially clinical cardiac arrest research, is in a population that is vulnerable in an emergency situation, and it requires, of course, alternative methods and processes to obtain consent. But what we would also stress in this is that we encourage patient and public involvement in resuscitation research along the line or along all stages of research, meaning in design, conduct, and dissemination of research. And just to bring that point home, because patient and public involvement is something that is, while it's been practiced for at least 2 or 3 decades, it is not always integrated and it's not always present. So just to make that clear, what we mean with patient-public involvement is it's research with patients, not just for patients, and it sees patients as partners. And overall, we believe this can boost the impact of the research we do, create trust within society, and then also increase the relevance of the research that we do. Going back to education and training, and Sabine kindly already alluded that there will be something on ethics there, and this is actually new. We made specific recommendations, suggestions for incorporating ethical reasoning and communication of ethical decision-making into resuscitation training. Here, we made some specific recommendations on the ways this can be done, and suggest, for example, that this can be integrated in simulation-based training or based on cases that are discussed within a hospital following, let's say, a difficult case, for example. Again, this is the overview of the key messages. I didn't go into the fifth one that is on bystanders and first responders. Of course, this is also hugely important, but there are many recommendations, many considerations that we include in the full publication. I would encourage you to read this and reflect on it. And with that, I would say here's my information. If anyone has any questions, they're welcome to email me, and I'll try to connect you to the expert within our writing group that knows the best or answer it directly. And also there's again the QR code to our publication. Thank you.
Thanks, Johannes, for this very nice summary. A first question immediately, and I like this because when I read this term for the first time, I also was a little bit struggled. What do you mean uncontrolled organ donation? I thought always organ donation is very controlled.
Yeah, that's a very good question, and I think when you come across on that, it might sound a little bit confusing in a moment. But this is organ donation also in the context of CPR, that what we discuss here, and of course what we highlight also in the guideline, that this is a very important consideration, and there's some say ethical considerations to be made, but what is very important also looking at termination of resuscitation, that policies that relate to uncontrolled organ donation, for example, do not conflict with termination of resuscitation rules and so on. Yeah, but I hope that answers your question, Tino.
The controlled means the standard procedure on an ICU if there's brain death and there's a clear plan of steps. This is runs under control, and uncontrolled is sudden cardiac arrest, rather quick decisions.
Exactly.
To explain the terms, yes. Okay. You mentioned teaching ethical principles. What would you recommend to educator, course organizers, people who are teaching basic life support? What should they include? What should they teach?
I think first of all, I think when we think about ethics in resuscitation, I think this is something that spans across any resuscitation attempt. You need to consider ethics. And when we train, we sometimes say, train as you fight. And I think we should always also consider all these decisions that we need to make in real practice in our simulation training, for example. So what should they consider? For example, having a simulation-based scenario where a team actually takes a team-based decision to do a termination of resuscitation. So that's for one example. Or to also train a situation maybe where this is CPR in the context of a suicide attempt. I think there are complex situations with which rescuers are being confronted, and training them allows them to reflect on it, to discuss them afterwards, and then also when they take care of patients, take adequate decisions and engage in ethical decision making.
Thank you, Johannes. Another question from the Q&A box about advanced plans. Do you think that paramedics can be part of this discussion, or this is something that should have been discussed in advance, or by professionals like doctors or family doctors, senior professionals?
So, of course, advanced care plans are important for paramedics in their practice, and they should be aware of that these plans exist, and they should be able to access them and understand them. Of course, the setting for having advanced care plan discussions needs to be adequate, and maybe remembering my time in the back of an ambulance, that is sometimes difficult, but they might still come up. And I think what is important is that pre-hospital staff and paramedics are also aware of this, can use them, and in essence, they are there to protect patient wishes. And so everyone who involved in patient care should be aware of that.
Thanks, Johannes, for this nice summary. Because time is running, we are going to the next part, which is also very important. And the first aid guidelines was a totally new concept this time. And Teresa Dier from Sweden will explain this to us. Microphone. Still can't hear you.
Now you can hear me. Thank you. Sorry, the button was gone. Thank you, and awesome to have you here and talk about first aid. First aid is very different from all the other topics because this is sort of we're trying to structure a helping behavior of humans in acute situations, and they might not be trained. Let's see if it's working and clicking. Yeah. First of all, I had an excellent writing group who really struggled hard, and we had laypersons, and we had non-medical people, we had medical people, paramedics, and all kinds of people trying to understand and really make it actionable and useful. And I'm very thankful for the team. my conflicts of interest. Yeah, there they are. So first aid is really the first link in the chain of survival where we can avoid cardiac arrest if we do it correctly. And the focus in the ERC guideline this year was actually to focus on life-threatening conditions. We tend to do a lot of first aid every day. We put on small plastics on children or something like that. And I mean, we don't need guidelines for that. We need guidelines for when we can do things very quickly, where it's time critical, and if we do it correctly, we will save lives or avoid cardiac arrests. So that's the focus of the guideline, which is very different from the last round. This is the key message from the guidelines. I will talk you through some of them. The first thing we did was actually trying to have a structural assessment, because as you heard, everybody talks about ABCD, and maybe laypersons and first aiders also would like to organize themselves in a way that's what medical dispatchers will talk about. So we try to learn them that way. Everything starts with check for responsiveness, because if the person is not responding or responsive, then you should call for help. First aiders don't have to diagnose. They have to call for help. That's always the first thing. And that's on top of every algorithm we have. Because if we try to diagnose, we will only delay. And that's not the point with first aid. And you can see it in all algorithms we have. This is for opioid poisoning, and this is for drowning. The same pattern. If they're unresponsive, call for help. And after that, open the airway. And this is one of the things we discovered with the guideline. We try to write the guideline in words, but it's very difficult to understand how to do a practical thing in words. So in this time, we also added nice movies. And this is a small movie. You can check the QR code and see how to open the airway in 2 different methods. And that's much better than writing it in words. So we have these nice videos. Yeah. And after that, this algorithm is also it's difficult to make an algorithm suiting every condition. Some say life-threatening bleeding, it should come before we even call for help. Maybe, but this is how we made it. And this is one of the things you have to discuss in your courses or settings, because life-threatening conditions and bleeding is definitely one of them. And we recommend an escalating approach in this. So first of all, do a manual pressure. Maybe you can do that first, and then you can do the call to the dispatcher. Or maybe you should do the call to the dispatcher first, and they're going to ask you for this and put the pressure on. But if you start the other way around with tourniquets, you have to find that and apply it, and you lose a lot of time. So that's why we have always this unresponsive, call for help. And then we try to do the ABCD. And we have it in our guideline, how to do ABCD, but also you see in the lay term version, which is a really nice summary of all the guidelines. And it's quite useful I use it a lot for my medical students and also my parents. They can read it. So this is for everybody. So please screen through it. It's really nice. And one of the things you discover when you start doing this and reading it, there are also specific conditions where you have to do specific actions. And this is one of them, anaphylaxis. And you have to understand there's a phrase where you recognize things, and then you have to treat and then reassess and repeat. And you have to understand that you don't do one of them. You have to align when you do first aid trainings, align the recognize, treat, and reassess as a chain of actions. And that's going to be life-saving if you do it like that. This is a new topic we had. Suicidal thoughts is, many people seem to think that it's even dangerous to talk about that. And if someone says, I'm thinking of ending my life, you should stop and move away. But actually the research is the other way around. You should ask them, what do you mean? How do you feel? Why do you feel that? Do you have plans? You can be quite specific on that. How, when? And then summarize. I hear that you actually want to end your life. But I know that you can feel better if you get the right help. So please, you will feel better soon. I'm going to help you now by calling for help. And this is really important to understand. This is actually decreases the risk for an actual suicide if you do these small steps. So we have included them in the first aid chapter as well. And also courses, first aid courses. There are so many courses out there. I think it's really important that we tailor them. Sabine has already talked about education and how we really need to think about effective methods. And we need to empower equity. So everybody can keep doing first aid and that every person needing first aid will get it. And one of the things is in this course is this is, if, for example, if you have heat stroke, if you live in a country or in a setting or you're working at maybe a marathon or something, this is going to happen. So you have to first learn the order of actions, like what to do first and then and the second part, and then train the practical actions you need to undertake so you know how to do them. And we try to make a nice picture here on how to do this cooling with a tarp and ice and water. But those of you who went to the Congress and to our workshop and really tried it out, we did this small plastic balls. I know you remember it. I know you will know immediately how to do this after the workshop. And this is one of the things we have to train first aid. If it's a practical moment, don't talk about them, do it practically, because that's going to be helpful. So that's how we want the future to be, these first aid courses, really think about how to do things. And my final slide is this. David Sideman, who did the last round of guidelines, he said that first aid is not a procedure, it's a social interaction. And I really want to add to that, this is actually the helping behaviors of humans. So we can't really be strict on what to do and what not to do, how to do it. We just have to give them advice and help them with pictures, videos, and practical training. So people can help each other and keep being social and keep the helping behaviors by adding life-saving things into first aid. So, and that's my final slide. Thank you for listening. Over to you, Tino and Natasha.
Thank you very much, Teresa, for this presentation about first aid. And I'd like to start with the first question from the chat. And this is, should we continue with ventilation even if we have identified a completely blocked airway?
Yeah, that's very difficult. It's very difficult for a first aider to really understand if it's totally blocked or not. And I think there is two ways to go. Start CPR. That's one way. If you have a cardiac arrest, start CPR. The other way to go is to keep ventilating harder to actually get the foreign body, which we are talking about now, into one of the lungs and keep ventilating the other one. But that's very tricky, and it's I think you need a dispatcher. You should call for help and get the dispatcher to help you out in this situation. If this is something happening very often in your setting, then you might have a tailored course on how to act and a local policy again, because this is definitely beyond first aid.
Thank you.
But Tessa, what are the first procedures if really something is struggling with breathing and they think they swallowed something?
Yeah, so keep coughing. Can you cough? Keep coughing. And then do the back stab on the back, and then you can do the abdominal thrust. And that's what we recommend, those chain of actions. And we do have a nice slide of that as well in the guideline. And you need to do more than one usually, most of the times.
Thanks. I would like to mention that for the first time in all the guidelines, we have QR codes which can show you either videos or additional algorithms or additional information. So go to the guidelines and look up these QR codes. You can find all this material, all guidelines, and also the layperson version free of cost at the ERC webpage. And there's a download center where you can download all of the stuff. And if there's a translation to your language, you can even choose on a drop list your language if there's a translation. So, and if there are new translations coming up, they will be added as an information for you. The question is, can you teach first aid to primary school students, very little kids, Tessa?
You can. You just have to adapt that because they are very willing to help and you should teach them what to do. I know that you have like 112 is a simple teaching method, how to call for help, things like that. Again, you have to adapt to that target group, but yes, you can.
Mm-hmm.
There is another question about first aid courses and CPR courses, and if they can be combined, but this is something that depends on resuscitation council, local resuscitation councils. And Tino, you want to add something on this?
So I think even the European Resuscitation Council and the local resuscitation councils provide resuscitation courses. First aid courses are mostly organized by rescue organizations, locals, emergency services, or the well-known Red Cross, St. John's organization, or elsewhere. They can, and usually what we recommend, or what is the recommendation in the education chapter, that you should attend a certified and accredited course, because we have evidence that if people attend such an accredited course, which means some authority looked at the course program, and if people attend these courses, more patients survive. So this is really, we have evidence that if people attend these kind of courses, they are doing better. There was another question. ABCD. ABCD is a method or an acronym helping you in a kind of diagnostic procedure. So you follow the steps down. SPAR, in contrast, is much more an acronym which helps you in communication, the patient situation. As a summary. Natasha, anything else?
One last question, guidance for respiratory arrest before cardiac arrest. I think this is something not specifically discussed, and also something that can not be very well. I'm not sure if this is referred to the first aid, but this is probably something that people are not very familiar with. If they don't have a healthcare background, but not specific guidance for respiratory arrest.
So, in contrast to the heart, we will talk about lung failure or respiratory failure. So that usually, if you have a heavy injury on your lung, this is a slower process. This is not in one moment you stop breathing, except in trauma, or yes, mostly as trauma. However, the difference might be that for children, very small children, the cardiac arrest reasons, or the reason behind the cardiac arrest is more on the pulmonary side. For the more older people, it's more on the cardiac origin, roughly. Good. Last question. Whenever possible, do ventilation, and if you have the opportunity, provide oxygen. In this moment, with low oxygen saturation, there's no danger from the oxygen side. Otherwise, I would like to thank all the speakers, because we are coming to the end, for this nice presentation. And my last question, we do a short round, is what is your take-home message? Johannes, starting with you.
Yeah, so my take-home message is, please think how you can integrate ethical decision-making into your training programs, your courses, and so that it can translate to clinical practice.
Good. Tessa, first aid?
Yeah, first aid training has to be practical and relevant to the participants.
And Sabine?
For me, the take-home message would be to consider targeting your education towards your respected targeted group of rescuers.
Good. With all this, Natasha, last words?
I think that our presentations today are very educational and reaching very different aspects of resuscitation science, which is amazing. So very nice to hear from all these great speakers.
Thank you all who were listening to these webinars. The ERC will go on with this program on different webinars. Please stay tuned, and very soon you will get the next topics of the next webinars. Thank you for your attention, and as usual, have fun.